Welcome back to the deep dive. Today, we are undertaking a mission to really change how you view the surface of the human body. We're talking about the integumentary system, the skin, hair, nails, and all the associated glands. For most of us, this system is simply the body's packaging. The thing we notice for cosmetic reasons or maybe when we get a sunburn.
And that is a really dangerous underestimation. Our sources make it crystal clear. The integumentary system is the body's systemic sentinel.
Systemic sentinel, I like that.
It's the visual, palpable manifestation of what is happening internally. Forget its superficial appearance. This system provides absolutely vital, rapid information about a patient's overall health status.
So it's reflecting things like hydration, oxygenation.
Exactly. Hydration, oxygenation, nutritional status. Often long before your heart monitor, your lab results confirm there's a problem.
I love that framing. It really shifts the perspective from just dermatology to comprehensive internal medicine. So our mission today is to turn simple observation into a crucial diagnostic skill. What does that journey look like for us?
Our deep dive is going to be a rigorous one. We'll start with a foundational anatomy, really understanding the layers and accessory structures.
Okay.
Then we immediately confront the critical, the truly emergent findings that require instant action. We'll master the art of structured subjective data collection because the patient's story is your map.
Right.
And finally, we'll execute a highly detailed, systematic, objective exam from checking the specific angle of a nail bed to identifying the precise language of a lesion.
The goal being to equip you with that foundational, detailed knowledge you need to interpret the body's fastest communication system.
That's it.
Okay, let's unpack this and start with the very foundation, the microarchitecture of this incredible protective barrier. Starting from the outside in, let's talk layers. The skin is often described as this three-layer marvel, and each layer has these distinct, non-negotiable functions. At the top, we have the epidermis. I tend to think of this as the security wall.
That's a good analogy. But it's more than just a wall. It's a self-renewing fortress. The epidermis is the outermost layer, and it's constantly regenerating.
So it's always rebuilding itself.
Always. And its primary job is forming that critical first line of defense. Think of it as the ultimate barrier. It prevents water loss, which is essential for your hydration status, and it blocks pathogens and harmful UV radiation.
And the cells here, they're packed really tight, right?
Incredibly tight, mostly keratinocytes, creating that effective seal. And if that seal is compromised, by a tiny crack from dryness or a major burn, the systemic consequences are immediate.
That structural integrity is absolutely key. So below that defense layer, we sink into the supportive, highly active middle layer, the dermis. This is where the bulk of the regulatory infrastructure lives.
Right. The dermis is the connective tissue powerhouse. It provides strength, elasticity. This is where you find the rich structures that regulate the entire body.
So what are we talking about here?
We are talking about blood vessels, which are crucial for thermal regulation nerve endings, for complex sensation, sebaceous glands that produce oil to waterproof the epidermis.
And hair follicles, things like that?
Exactly.
Yeah.
Lymphatic vessels for immunity, and the roots of hair follicles and sweat glands, it's all in the dermis.
The dermis's role in temperature regulation is fascinating. So when you're hot, those blood vessels dilate, they flush the skin, and that's what allows heat to escape through radiation.
Precisely. The vascularity here is dynamic. In cold conditions, they constrict, shunting blood inward to protect your core temperature. This ability to rapidly constrict or dilate is why checking the skin's temperature and color provides such an instant snapshot of cardiovascular function and environmental response.
And finally, we hit the deep layer, the subcutaneous layer, or It feels like it often gets the least clinical attention, but it's fundamental to protection.
It is. The subcutaneous layer is primarily composed of adipose tissue fat. Its functions are profound. First, it provides thermal insulation, acting like a blanket. Second, it's a major storage depot for energy. But clinically, its role in protection and skin mobility is vital. That fatty cushion absorbs shock, protecting the deeper structures like muscle and bone.
And it lets the skin move around.
Exactly. Its mobility allows the skin to move freely over those underlying structures. If a patient is malnourished or, severely emaciated, they lose this layer. And their risk for pressure-related injury just skyrockets because they lack that critical cushioning and mobility.
Moving beyond the skin itself, let's look at the secondary structures, starting with hair. It serves protection, insulation, and surprisingly, sensory input. We categorize hair into two major types based on density and pigmentation.
Right. We distinguish between vellus hair and terminal hair. Vellus hair is that fine, short, often hypopigmented peach fuzz.
The stuff that covers most of your body.
Covers most of the body, and while it seems trivial, it is intimately associated with touch receptors. Our sources highlight that vellus hair acts almost as a lever, relaying these subtle sensory inputs to the nerve endings in the dermis.
So even the lightest breeze or the brush of clothing is registered by the vellus hair acting as a kind of antenna.
Precisely. Then we have terminal hair, which is the coarser, darker, and thicker hair. This is what provides more substantial insulation and protection, primarily found on the scalp and brows.
And the distribution of terminal hair is a rapid visual cue of hormonal status, especially after puberty.
Absolutely. The post-pubertal development of terminal hair is a direct reflection of androgen activity. This coarse hair appears in the axillae, the perineal area, and the legs for both males and females.
And for males, there's more.
For males, we see additional terminal hair development on the chest, abdomen, and sometimes the back. Changes in the density or appearance of this hair later in life, such as thinning in women or unexpected coarse growth, are often immediate red flags for endocrine shifts or underlying disease processes.
Okay, let's shift our attention to the nails. They seem like these static, simple structures, but they offer a wealth of clues about long-term systemic health. What are they fundamentally made of?
The nail plate is compressed, hardened keratin. It's formed in the nail matrix near the cuticle and slowly pushed forward. What is critical, however, is the nail bed underneath the plate.
And that's highly vascularized.
Incredibly vascularized. This rich vascularity serves two clinical purposes. It allows us to quickly assess peripheral perfusion using capillary refill, and it explains the intensity of trauma.
That trauma point, a subungual hematoma, that's basically a blood blister under a hardened, unyielding plate.
Yes, when trauma occurs, the blood vessels burst, and blood collects in that subungual space. Because the hardened keratin plate prevents the fluid from expanding outward, the pressure builds immediately, and that leads to intense throbbing pain.
Which is why, clinically, it often requires decompression. You have to drill a small hole in the nail to relieve that pressure.
You have to.
And here is a fun but clinically relevant tidbit. Fingernails grow faster than toenails. I've heard theories that it's related to microtrauma or maybe overall circulation.
That speed differential is real, and the growth rate is highly instructive. On average, fingernails grow about 3 millimeters per month, while toenails grow closer to 1 millimeter per month.
And the clinical significance of that.
It's massive. Since the nail is constantly growing, it essentially acts as a linear timeline of your systemic health. Major infectious processes, acute illnesses, or severe nutritional deficiencies, like a rapid onset of anemia, can cause growth interruptions or visible defects.
Like Bow's lines.
Exactly, like Bow's lines, those transverse depressions. And they can appear weeks or even months later. The nail structure provides a durable physical record of past systemic insults.
So we understand the structure. Now we confront the immediate challenge, triage. Unlike a patient presenting with crushing chest pain or, acute shortness of breath, most skin, hair, and nail findings are, thankfully, non-emergent.
Right, a bad rash or chronic dry skin can wait. That established stability is key.
But there are exceptions.
However, there are a few exceptions, critical findings, where the integumentary system is sounding a catastrophic alarm. These are the red flags that demand immediate intervention, often indicating a problem in another system entirely.
Okay, let's focus on those immediate intervention findings, starting with potential malignancies.
The primary integumentary emergency that requires rapid referral or intervention is the suspicious lesion. We are talking about the early identification of potential melanoma.
So finding a mole isn't the emergency.
No. But finding a mole that is rapidly evolving, changing size, shape, or color, that is a time-critical issue. Immediate biopsy and diagnosis dramatically impact prognosis.
Then we have the visual markers of systemic distress, where the color of the skin reflects oxygenation and fluid balance.
Correct. We look for indicators of severe circulatory or volume compromise. This includes moderate to severe dehydration, which we'll discuss how to check objectively later. But the key color changes are cyanosis, which is blue, and ashen, which is gray.
Can you elaborate on the difference between blue and gray in this context? Because they both sound pretty bad.
They do. Cyanosis, the bluish tint, is usually due to an increased concentration of deoxygenated hemoglobin blood that's given up its oxygen. It's concerning, signaling respiratory or circulatory issues.
But ashen is worse.
However, ashen skin, often described as a pale, severe gray color, can be a sign of far worse perfusion. It indicates severely impaired blood flow and profound oxygenation issues, often signaling shock or massive hemorrhage, where not only is the oxygen low, but the total volume of blood reaching the skin is drastically reduced.
So it's a marker of circulatory failure.
That's it. It's a powerful distinction for triage. Action often implies a more urgent, deeper systemic crisis.
Absolutely. Finally, we address acute physical trauma. Impaired skin integrity via major lacerations and burns.
Right. For large lacerations, the instruction is clear and it's always about priority.
Which is?
The absolute immediate priority is to control bleeding. If the laceration is severed an artery, you have high pressure flow, a true life-threatening event. Stopping that flow through direct pressure or tourniquet application takes immediate precedence over everything else.
Before you even think about cleaning the wound.
Before anything else.
And then the crisis that a major burn represents. Our sources emphasize that a burn is a systemic catastrophe, not just a skin injury. We really need to go into depth on why that is.
This is where understanding the dermis and epidermis barrier function becomes so critical. With a large, deep burn, say, a full thickness burn covering 20% or more of the body, the structural integrity of the skin is annihilated.
The barrier is gone.
Completely. The body instantly starts rapid fluid loss. The fluid, which is highly proteinaceous and electrolyte-rich, leaks out of the compromised capillaries and shifts massively from the vascular space, where it's needed for blood pressure, into the interstitial space, the burn tissue.
So the patient essentially develops massive internal swelling while simultaneously losing all their circulatory volume externally and internally. It's a double hit.
Exactly. This causes immediate, severe hypovolemic shock circulatory collapse due to lack of volume. Furthermore, this rapid shift involves massive losses and imbalances of critical electrolytes, especially sodium.
And this is what's so lethal in the initial hours.
It is. Most fatalities from large burns in the initial hours are due to this volume depletion and profound electrolyte shifting. The management protocol is hyper-aggressive and immediate. Rapid fluid replacement, often measured in liters per hour, to maintain perfusion, alongside meticulous electrolyte monitoring and management. It is a race against time to replace the volume the body is dumping.
Once the immediate emergent findings are addressed, we can move into the foundational step of gathering subjective data, the patient's story. If the skin is the sentinel, the patient's words are the key to interpreting the signals. So what are the most common chief complaints?
The chief complaints are typically symptoms they can feel or see. Pruritus, which is itching, the presence of a new rash, a single lesion or wound, or a concerning change in a pre-existing lesion or nevi, a mole.
If the patient says, "I have a rash," that is just the headline. The deep dive into the complaint is structured using the HPI mnemonic. Old cards. Let's demonstrate how applying this structure yields crucial diagnostic differentiation.
We use old cards to capture the full scope and nature of the problem. It lets us categorize the issue as acute, chronic, localized, or systemic. So O is onset.
When did it start?
Precisely. A sudden onset rash after taking a new medication suggests an acute drug reaction. A gradual onset over months suggests a chronic condition like psoriasis.
Next is L, location. Where did it start and where is it now?
And this can be a huge clue. A rash, starting on the palms and soles, is highly suggestive of specific, serious systemic infections, like secondary syphilis or Rocky Mountain spotted fever. That's a major differential compared to a rash localized to the neck from, a new piece of jewelry.
D for duration. Constant, or does it come and go?
Right. Intermittent symptoms might suggest an allergic trigger they encounter irregularly. Then C is characteristics. What does it feel like? Is it burning, tingling, painful, or just deeply itchy?
And that matters because?
Because pain often suggests neurological involvement, like herpes zoster, while deep, relentless itching or pruritus can point to liver disease or kidney failure, not just a superficial irritation.
A is aggravating alleviating factors. What makes it better or worse?
This is crucial for distinguishing conditions. If washing with soap makes it worse, you might have contact dermatitis. If cold compresses help, it might be an inflammatory process. R is radiation. Does it spread?
Less common for skin, I'd imagine.
Less common, but sometimes dermatomal, nerve pathway pain, or itch spreads, offering a clue to a nerve-related disease. T is treatments. What have they tried already? Did OTC hydrocortisone help? Did an antibiotic cream make it worse?
Knowing what failed is often as important as knowing what worked.
Sometimes more important. And finally, S for severity. How bad is the itching or pain? A 10 out of 10 itch that keeps them awake is highly significant compared to a minor, occasional bother.
That detailed analysis of the complaint is one piece, But we also need the comprehensive historical checklist data points that might reveal the underlying susceptibility.
This includes a deep dive into their past medical history, or PMH, and a comprehensive review of systems. We need to check for diabetes, autoimmune conditions, or previous episodes of skin cancer.
And family history is huge here.
Exceptionally important. Are there familial components to psoriasis, eczema, or, critically, a family history of melanoma?
Let's talk about medications. This is an area where the link to the integumentary system is often overlooked, but the consequences can be severe.
It's a massive factor.
Yeah.
We must look at two sides of the medication coin. First, check for current medications that might be causing issues. Many classes of drugs, like certain antibiotics, diuretics, or even common pain relievers, can cause phototoxicity.
Increased sun sensitivity.
Right, leading to severe burns or unique rashes upon sun exposure. Second, we must confirm any medications the patient is already taking specifically for a diagnosed skin, hair, or nail condition. That informs us about their baseline health status.
And bringing it back to prevention and risk, the assessment of lifestyle and personal habits is non-negotiable.
This informs the long-term risk profile. We need specifics on hygiene practices, not just if they clean, but how often and what products they use, as harsh products can compromise that epidermal barrier.
But the big one is sun exposure.
The most vital component is quantifying their sun protection practices. Regular use of SPF, wearing protective clothing, time spent outdoors, and specifically exposure to artificial UV lights, like tanning beds.
Which are significant risk factors for melanoma.
Huge risk factors. And if they have occupational exposure, like working construction or farming outdoors, that immediately elevates their risk profile and dictates surveillance frequency.
Now we transition from the subjective story to the objective assessment. Let's start with hair and scalp, using both inspection and palpation. What defines a normal finding?
We expect the hair to be equally and symmetrically distributed. No patches of loss unless it's a genetically determined pattern. The hair shaft should be structurally sound, smooth and shiny, without evidence of breakage.
And the scalp itself.
The scalp color should be consistent with the rest of the body, suggesting adequate perfusion. When you palpate, the hair should feel smooth and be firmly adhered to the scalp. You shouldn't be able to pull it out easily.
Okay, now for the red flags in hair assessment that point away from superficial problems and toward systemic ones.
Brittle or broken hair is a major clue. When the hair shaft is dull, dry, and fractures easily, it suggests issues with the building blocks, protein, iron, vitamins, or, critically, underlying endocrine or metabolic dysfunction.
Most famously, thyroid problems.
That's the classic example. Both hyperthyroidism and hypothyroidism can cause significant changes in hair texture and loss.
What about hair loss patterns or alopecia?
Alopecia is pattern hair loss. While the most common forms are genetic, like male and female pattern baldness, sudden or patchy loss. Alopecia areata is often linked to autoimmune issues.
And what about unexpected hair growth?
When you find unexpected hair growth in women, that is, hirsutism, indicating an excess of androgens or underlying conditions like polycystic ovary syndrome, and of course we must check for surface issues like lice or other infestations, or the presence of flakes or crust on the scalp.
Moving to the nails, the visual assessment here is about long-term perfusion and oxygenation. The expected state is straightforward. Nails should be smooth and consistent in color, but the real structural check is the nail angle.
The nail angle is a profound indicator. We're looking at the angle where the proximal nail fold, the skin, meets the nail plate. The expected normal finding should be less than or equal to 160 degrees.
There's a trick to check that, right?
There is. If you put two fingernails together back to back, you should see a small diamond-shaped window between them. That's the normal angle.
Okay, let's look at the spectrum of abnormal findings, which often tell a specific story.
Thickened nails often indicate a chronic, persistent issue, most commonly a fungal infection, or onychomycosis, especially prevalent in the toenails of older adults.
And discoloration.
Discoloration warrants deep scrutiny. White or yellow changes often indicate fungus, but black or brown discoloration can be from trauma, or, critically, a longitudinal brown or black streak could be a melanoma appearing under the nail.
The classic finding for chronic respiratory or cardiac disease is nail clubbing. Let's explore the physiology here, moving beyond just the definition.
Clubbing is where the nail angle dramatically changes, becoming greater than 180 degrees. That diamond window disappears, and the fingertip swells and feels spongy.
And physiologically, what's happening?
Physiologically, clubbing is a response to chronic hypoxia. In long-standing oxygen deprivation, like from severe COPD, emphysema, or congenital heart defects, The body compensates by releasing vasodilators into the peripheral circulation. These substances eventually affect the soft tissue and nail matrix at the fingertip, causing that characteristic swelling and loss of the acute angle.
So it's not an acute finding, it's a sign that the patient has been struggling to oxygenate effectively for months or even years?
Precisely. It's usually not emergent in the moment, but it's a definitive sign of a severe chronic underlying pulmonary or cardiovascular issue that needs aggressive management.
And then there's the distinctive spoon nail, or quilanchia.
Quilanchia is unmistakable. The nail develops a distinct concave, scooped out, or spoon-shaped depression. While severe trauma can sometimes cause this, it is the classic textbook sign of iron deficiency anemia.
So the body is so starved of iron that the nail plate development is just structurally compromised.
That's exactly it.
After visual inspection, we move to palpation and the vital perfusion check. Palpation of the nail bed should be quick.
Palpation confirms the texture and adherence. Nails should be smooth, non-tender, and firmly adhered to the nail bed. Swelling or tenderness, especially around the edges, often suggests a localized bacterial or fungal infection, like paronychia.
And the ultimate rapid assessment of peripheral circulation, capillary refill.
This is a cornerstone of objective assessment. The technique requires pressing lightly on the nail bed, maintaining pressure until the area blanches white, indicating blood has been briefly shunted out. Upon release, you count the seconds until the color returns to its normal pink.
And the expected finding is very quick.
The expected finding is a return of color in less than or equal to 3 seconds.
What does a delay beyond 3 seconds tell us about the patient's status?
A prolonged refill time indicates poor peripheral perfusion. This could be due to systemic issues like hypovolemia, dehydration, shock peripheral vascular disease, or even just severe cold exposure. It's a fast, non-invasive way to assess how effectively the heart is pumping blood to the extremities.
And a practical note, if the patient has dark nail polish or artificial nails, what's the workaround?
You have to adapt. You can check capillary refill on the finger pad or even on the skin of the forehead, anywhere with adequate vascularity to ensure you get an accurate read.
Now, for the general assessment of the skin itself, this requires a rigorous, systematic approach. You can't just eyeball the exposed areas. You need to execute a full head-to-toe survey.
Systematic is the key word. The inspection must start at the crown of the head and progress methodically toward the feet, assessing every area for scars, bruises, and lesions. The most important clinical takeaway here is to inspect the crucially missed areas.
Where are these blind spots that often hide critical pathology?
The palms of the hands, the soles of the feet, and especially the spaces between the fingers and toes. These areas, because they are non-sun exposed, are often overlooked during self-exams and clinical exams.
Yet they're common sites for aggressive forms of melanoma.
Exactly. They can be caught too late simply because they were not checked. The overall goal is to confirm that the pigmentation is generally consistent throughout the body, allowing for normal variations, like sun-exposed areas being darker.
When we do find abnormal color variations, we move to precise documentation using standardized terminology. Let's define the 4 major changes.
Okay, first is erythema. That's redness, indicating inflammation, fever, or increased localized blood flow.
Then cyanosis.
Cyanosis is blue discoloration, signaling insufficient oxygen saturation in the blood. Third is pallor, which is paleness, reflecting decreased blood flow or anemia. And finally, jaundice.
Yellowing of the skin.
Yellowing, classically a sign of liver failure or obstruction due to elevated bilirubin levels.
Now, let's address a critical practical challenge. Assessing these color changes in patients with darker skin tones, where external pallor or cyanosis can be obscured. Where is the reliable sentinel site?
You have to bypass the heavily pigmented epidermis and look directly at the vascularity. The mucous membranes inside the mouth, the gums, the conjunctivae, which is the lining of the eyelids, are the best check sites.
Because they're so highly vascular.
Right, and they typically maintain a consistent pink color unless systemic issues are present. A change to gray for pallor or cyanosis, or a noticeable yellow tinge for jaundice at the gums or conjunctiva is a definitive finding, regardless of the patient's external skin tone.
Once inspection is complete, we turn to skin palpation, focusing on 3 key indicators: temperature, moisture, and turgor.
Temperature must be checked using the dorsal surface of your hand, the back of your hand, as it's much more sensitive to subtle temperature variations than the palm.
And you're looking for symmetry.
Exactly. Expected findings are warm or cool, consistent with the environment, and symmetrical between body parts. Abnormal findings, localized coldness or generalized heat, can point to circulatory compromise or severe infection.
And for moisture.
We use the palmar surface to assess moisture content. Expected finding: consistent, mild moisture. Abnormal findings range from extreme dryness and cracks, which immediately compromises the defensive barrier and risks infection, to diaphoresis,
Excessive sweating.
right, which can be an autonomic response to pain, fever, or metabolic distress.
Finally, checking the body's hydration status using skin turgor. This is a measure of elasticity.
Skin turgor assesses the hydration status of the dermal layer. We gently pinch a fold of skin. In a well-hydrated patient, the skin snaps back promptly. We call this brisk recoil. The abnormal finding is tenting.
Where the skin fold remains elevated or slowly returns to position for several seconds, a classic sign of dehydration.
It is, due to the loss of fluid volume in the tissues.
I have a probing question from our source material on this. For older adults, is tenting always indicative of dehydration, or can it just be an effect of decreased age-related elasticity?
That is a critical point that clinicians often miss. Age does reduce skin elasticity naturally, especially on areas like the hands or forearms. So checking turgor on an elderly patient's hand might show false tenting.
So where's the best place to check for an accurate read?
To get the most accurate read on actual hydration status, you must check turgor on a site protected from sun damage and natural aging effects, typically the clavicle, just under the collarbone, or the sternum. If tenting occurs there, it is far more reliable evidence of true dehydration.
To communicate findings accurately, the listener must become fluent in the language of dermatology. This means knowing the precise difference between the primary lesions. Let's detail the 5 most common types.
Precision here is essential for documentation and diagnosis. First up, maculas. These are flat, visually distinct areas, defined borders, and they are non-palpable. They are typically small, less than 1 centimeter.
Like a freckle.
Exactly, like a freckle or a small area of a first-degree burn. Then we have papules. These mark the shift to palpable lesions. They are raised, circumscribed, solid, and palpable. Also typically less than 1 centimeter. A classic small mole.
Next are nodules.
Nodules are deeper and larger versions of papules, still raised, circumscribed, solid, and palpable, but measuring 1 to 2 centimeters, often extending into the dermis or subcutaneous layer. Think of a larger wart or a deep cyst.
Pustules. The name says it all.
Right, the key word is pus. They are raised and filled with purulent material. They can vary in size. The classic example is acne.
And finally, vesicles.
Vesicles are raised and filled with clear or serous fluid. They're typically small, less than 1 centimeter. The critical clinical distinction here: a vesicle contains clear fluid, while a pustule contains pus. Examples would be a tiny blister from friction, or the characteristic lesions of a cold sore or herpes.
Why is distinguishing between a vesicle with clear fluid and a pustule with pus so critical in triage or diagnosis?
It immediately guides the differential diagnosis.
Right.
Clear fluid often points toward acute, non-infectious causes like friction or burns, or specific viral causes like herpes. Pus, by definition, is a collection of dead white blood cells, which strongly indicates a bacterial process or intense localized inflammation that may require specific antibiotic treatment.
Beyond primary lesions, we must recognize lesions that are the direct result of trauma or bleeding under the skin.
These are the markers of vascular fragility or injury. First, petechia. These are tiny pinpoint reddish to purple macules that represent minute bleeding from capillaries, and they're non-blanching when pressed.
So they can signal something serious.
They can. While minor trauma can cause them, they can also signal critical underlying blood clotting disorders. Then you have purpura, which is similar but significantly larger purplish macules or papules representing deeper bleeding.
And the more common ones.
Right. Other common trauma includes ecchymosis, a common bruise, hematomas, which are a solid localized collection of blood, lacerations, a deep cut, and abrasions, a superficial scrape.
We also assess for lesions resulting from infection, inflammation, and infestations.
This is a huge category. It covers chronic inflammation like psoriasis with its silvery scales and eczema with itchy dry patches. It covers acute infections like herpes and simple reactions like insect bites.
And for infestations.
For infestations, we look meticulously for lice, including the nits adhered firmly to the hair shaft, and scabies, which often present with intense itching and burrow marks, particularly in skin folds.
Finally, once we've identified the morphology, we must accurately document the pattern and distribution of a widespread rash. This descriptive language is vital for communication.
Think of this as the geographical description. Is it symmetrical or asymmetrical? Is the rash distributed equally on both sides or solely on one side, like with herpes zoster or shingles, which follows a nerve path?
Then discrete versus confluent.
Right. Discrete means the lesions are isolated, single, separated with well-defined borders. Each one is its own island. Confluent means the lesions are joining or running together, coalescing to form large, continuous patches. This often happens in severe allergic reactions.
And diffuse or generalized?
Diffuse means it's distributed widely across the affected area without any specific grouping or pattern. Generalized means it's over a large body area, like the entire trunk and limbs. And then localized is just confined to a distinct, specific area, like the left inner thigh.
In the end, what are the three mandatory pieces of information that must accompany morphological name?
The final, non-negotiable details for documentation are the lesion's precise size, in centimeters or millimeters, its color, and its exact body location. Without this, the next clinician cannot track its evolution.
We shift now to proactive health promotion and risk assessment. The first major tool for skin cancer screening is the ABCDE rule for abnormal moles.
This mnemonic is designed for both clinicians and patients performing self-examinations, inspecting for growths, tumors, or vascular lesions that might signal melanoma. We need to drill down into what each letter means clinically.
Let's do it. A is for
Asymmetry. If you draw a line through the mole, is one half unlike the other? Melanoma often lacks the uniform roundness of a benign mole.
B is border irregularity.
Are the edges ragged, notched, or blurred? Benign moles typically have smooth, distinct borders. C is color variation. Does the mole contain multiple shades, brown, black, tan, or even red, white, or blue? Multiple colors in a single lesion are a major alarm sign.
D is diameter.
Is it larger than 6 millimeters? About the size of a standard pencil erasure? While size doesn't guarantee malignancy, larger lesions have a higher risk.
And finally, E, which some argue is the most important.
It is. E is for evolution. Is the mole changing over time in size, shape, color, or elevation? Has it started itching, bleeding, or developing a crust? This E for evolution is arguably the single most important sign, as it captures rapid cellular change.
Given the gravity of melanoma, what are the key risk reduction messages we, as clinicians, must reinforce consistently?
We must emphasize sun safety not just as a recommendation, but as a critical life habit. This means avoiding peak UV hours 10 a.m. to 4 p.m., wearing protective clothing, and using broad-spectrum sunscreen consistently.
And encouraging self-awareness.
Absolutely. We need to teach patients how to perform thorough skin self-examinations and stress the importance of professional dermatology visits, especially for high-risk individuals. And finally, the unequivocal avoidance of artificial UV light sources, particularly tanning beds.
The second major specialized risk assessment is focused on pressure ulcers and chronic skin breakdown, a massive issue for mobility-impaired or hospitalized patients. We use a precise classification system to describe the depth of these wounds.
This staging system is essential for accurate documentation and treatment planning. It describes the extent of tissue damage due to sustained pressure, usually over a bony prominence, leading to localized ischemia or lack of blood flow.
So stage 1, what does that look like?
In stage 1, the skin is intact, but you see non-blanchable redness. This means when you press the area, the skin stays red. The ischemia has begun, but the epidermis is not broken.
Stage 2.
Stage 2 is a partial thickness wound. It extends through the epidermis and potentially into the dermis. It presents as an open sore or a fluid-filled blister.
And stage 3 gets deeper.
A full-thickness tissue loss. Crucially, the subcutaneous fat tissue is visible, but bone, tendon, or muscle are not exposed.
Which brings us to stage 4.
The most severe, full-thickness loss, with direct visualization of exposed bone, tendon, or muscle, the damage is massive and deep.
And there's one more category, right? Unstageable.
Right. Unstageable means the wound is full thickness, but the depth is unknown because the base is obscured by slough, that yellow, soft, stringy necrotic tissue, or Escher, which is a dark, hard, leathery necrotic crust. You cannot stage it until that non-viable tissue is debrided.
To predict who is likely to develop these debilitating ulcers, we use a structured scoring tool.
That is the cornerstone of preventative care. The Braden scale. It's used globally to assess the risk of skin breakdown, generating a score between 6, which is the highest risk, and 23, the lowest risk. The key concept for the listener is, the lower the score, the higher the risk for integrity issues.
What are the 6 key factors the Braden scale forces us to assess, and how do they contribute to risk?
The 6 factors paint a comprehensive risk picture. Number 1 is sensory perception. Can the patient feel pressure or pain and respond appropriately? If they can't feel, they won't shift position.
Number 2 is moisture.
Is the skin constantly wet from incontinence or sweat? Moisture softens the skin, making it more vulnerable to breakdown. 3 and 4 are activity and mobility. How often do they walk? Can they change their body position on their own?
Then nutrition.
Is the patient consuming enough protein and calories to sustain and repair tissue? Poor nutrition severely hinders healing. And finally, friction and shear.
This one is often misunderstood.
It is. Friction is skin rubbing against a surface. Shear occurs when the skin stays put but the deep tissue slides over the bone, like when a patient slides down in bed. Shear is far more damaging than friction, tearing the capillary beds and causing deep tissue ischemia.
This entire discussion leads directly to the core care concerns we address in the nursing process.
The primary diagnoses we use reflect the compromised protective role of the skin. Impaired skin integrity for stage 1 or 2 ulcers, impaired tissue integrity for stage 3 or 4, indicating deep damage, and the ever-present risk for infection because that physical barrier has failed.
Let's make sure we integrate lifespan and cultural considerations because the Sentinel's message changes dramatically with age and ethnicity, starting with older adults.
The aging process fundamentally compromises the integumentary system. Their skin is thinner and more translucent due to atrophy of the epidermis and dermis, making it tear easily.
And we talked about decreased turgor.
Right. They exhibit decreased turgor, even in well-hydrated individuals, leading to increased wrinkling and laxity. Wound healing is significantly slowed due to decreased blood flow and cellular turnover. Hair thins on the scalp and pubic areas, and while nail growth slows, the toenails often become thicker and brittle.
For pediatric findings, we expect brisk elasticity, but some findings are immediate signs of neglect or deficiency.
In infants, we must track the development of hair and skin. Dull, brittle, or dry hair is a strong, non-specific indicator of nutritional deficiencies. Localized hair loss in infants may indicate they are spending too much time in one consistent position, positional alopecia.
And during puberty.
We must also carefully assess secondary hair growth during puberty as part of the endocrine system evaluation.
Our sources provide important distinctions regarding pediatric vascular lesions.
This is key for parental education. We distinguish between a hemangioma, a vascular lesion that rapidly proliferates in the first year of life, but then spontaneously resolves by age 9 without intervention,
Versus a port wine stain?
versus a nevus flammeus, or port wine stain. The nevus flammeus is a congenital malformation that grows with the child, never resolves spontaneously, and may require specialized laser treatment.
Finally, respecting cultural specifics is paramount for accurate assessment and avoiding misinterpretation.
We need to be aware of expected variations. In African Americans, we see an increased incidence of keloid formation, those tough, elevated scars that extend beyond the original boundary of the wound. They also have higher rates of melasma, the mask of pregnancy.
And Mongolian spots.
We must recognize Mongolian spots. Bluish-gray macules, which are benign and common on the backs of newborns and children of African, Asian, or Hispanic descent.
And addressing traditional practices is critical to prevent a misdiagnosis of abuse.
Absolutely. Traditional homeopathic treatments must be recognized for what they are. In Arabic and Indian culture, the application of henna tattoos and piercings is common. More urgently, practices like cupping, which involves heated cups applied to the skin, leaving large circular bruises. And coining, where heated objects are rubbed vigorously on the skin, leaving linear abrasion-like marks. A clinician unfamiliar with these practices might misinterpret the resulting ecchymosis or abrasions as signs of trauma or abuse, leading to an unwarranted investigation. Recognition and cultural humility are essential.
To wrap up the objective assessment, let's briefly mention the specialized diagnostic tools used when the clinical picture is ambiguous or deeper investigation is required.
These tools move beyond basic inspection. A superficial scraping of the skin allows us to collect cells or fungal hyphae for microscopic examination.
Then you have a biopsy.
A biopsy is required for a definitive diagnosis of malignancy or complex skin conditions, providing tissue samples. We also use wound cultures to identify the specific infectious agents.
And there are specialized lights and scopes.
All right. The Woods lamp, a form of UV light, can be used to visualize specific infections, like scalp fungus. And the episcope is a handheld magnifying tool used to closely inspect lesions, often with immersion oil, to visualize deeper structures and assess border and color patterns in detail. We've traveled from the invisible barrier of the epidermis to the precise measurements of the Braden scale. What this deep dive reveals is that the integumentary system is not merely packaging, it is the body's loudest alarm system and its most accessible historical record.
Exactly.
The minute details, the angle of the nail plate confirming chronic hypoxia, the moisture level indicating metabolic distress, or the presence of tenting signaling dehydration all connect back to overall systemic health.
And the power for the listener lies in the systematic approach. You must train your eye to look at those overlooked sentinel sites, the palms, the soles, the mucous membranes. You must master the terminology. Knowing the difference between a confluent rash and discrete vesicles is the difference between accurate communication and clinical confusion.
What stands out to me, having gone through the sheer volume of structural information and damage classifications, is the enormous task the body faces in repairing itself after a severe compromise, particularly those full-thickness defects like stage 3 and stage 4 pressure ulcers.
So here's the final provocative thought for you, the learner. We've covered the signs of injury and disease. Now, build on the concept of tissue integrity. When the skin barrier is completely breached after the fluid shifts and initial crises are managed, we know general nutrition is vital for healing. But what specific micronutrients and macronutrients, the very building blocks, are absolutely critical for rapid, efficient, and scar-minimized repair of those deep, full-thickness stage 3 or stage 4 defects? Think about the specific roles of high-quality protein, vitamin C, and zinc in rebuilding collagen and stabilizing the compromised sentinel. Keep that thought in mind as you continue to explore the vital role of the integumentary system.